This is NNI Bites, Big Learnings, a podcast where fellow healthcare professionals converse about the latest in nutrition science. We are joined by the chairs and speakers of NNI and WNSC Workshop 103 as they share practical insights on early life nutrition and its impact on children's long-term well-being.
Welcome to NNI Bites, Big Learnings. I am Professor Yvan Vandenplas, based in Brussels, Belgium, and today I have the pleasure of speaking with Professor Nadja Haiden from the Medical University of Vienna, a leading expert in neonatal nutrition and preterm infant care. Professor Haiden, thank you for joining us.
Well, thank you for having me.
It's my pleasure. I have some questions for you. So, Professor Haiden, what are the most important elements that support a smooth nutritional transition from preterm infants going home after discharge from the neonatal intensive care unit?
Well, the transition home is a very vulnerable period for preterm infants, and the nutritional continuity is key. Parents suddenly move from a highly supervised medical environment to self-directed feeding. A smooth transition requires, therefore, a clear written feeding plan, including recipes, target volumes, desired weight gain, and the type of formula or fortifier that breast milk is fortified with, and also micronutrient doses. Follow-up appointments must be pre-booked before discharge, so parents know when they have to come to the hospital again, and parents should know whom to contact if any drops or feeding problems occur. For example, lactation consultants or a physician they trust. Equally important is parental education, so the understanding of hunger and satiety cues, safety preparation, and when to seek help. So a close collaboration between NICU or outpatient clinic teams, community pediatricians, and lactation consultants ensure consistency and confidence at home for the parents.
Okay, thank you. The next question is about standards and pitfalls about monitoring growth. So, how should clinicians monitor growth in preterm infants after discharge? Are there specific growth charts or parameters you recommend? And why is weight for length Z-score so important?
Yeah, growth should be monitored using Z-scores rather than raw percentiles. Up to term, we should use the Fenton growth charts. These are also recommended by the WHO. And there are a mixture of intrauterine and extrauterine growth charts for length, weight, and head circumference. So unfortunately, for this time period, Z-scores are not available. But after term, physicians should switch to the WHO standards around 44 weeks of gestation and focusing on the length and weight for length Z-scores. The weight for length Z-scores are especially important. They reflect proportional growth and help to distinguish healthy catch-up from excessive fat gain. Rapid weight gain with poor linear growth often indicates an imbalance between energy and protein intake. Growth, therefore, should always be interpreted longitudinally, looking at trends over time rather than single values.
Okay, thank you. Then I have a question about faltering growth. So, which infants are at highest risk for post-discharge growth faltering, and what signs should prompt intervention?
Yeah, the infants at highest risk for growth faltering are those with a complicated course in the neonatal intensive care unit. So usually the extreme low birth weight infants with a small gestational age and a very low birth weight. Usually these infants suffer from morbidities that are associated with prematurity, for example, bronchopulmonary dysplasia, necrotizing enterocolitis, or other surgical complications. Then another group at high risk are infants with feeding disorders or congenital malformations that they have additionally to their prematurity. And warning signs could be prolonged feeding times, vomiting, crossing down growth percentiles, especially when they lose more than 2 standard deviations from birth. It is important to recognize these signs early and start nutritional interventions. For example, temporary reintroduction of fortifiers or nutrient-enriched formulas. Depends a little bit on the country what is available, but basically these interventions are crucial to prevent long-term deficits.
Yes, you mentioned growth is, of course, very related to food intake. So, in your lecture, you highlight both the benefits and challenges of breastfeeding preterm infants. Can you explain the breastfeeding paradox and the role of breast milk fortification after discharge?
Yeah, of course, we know that breast milk is the optimal nutrition for all infants, but also especially for preterm infants, because we know that breastfeeding or the feeding of human milk is associated with a significant reduction of morbidities related to prematurity, for example, necrotizing enterocolitis, sepsis, retinopathy of prematurity, and they also reduce later metabolic risk in the young adulthood. However, exclusively breastfeeding preterm infants is often associated with a slower weight gain. And this is what we call the breastfeeding paradoxon. So this means that initially these breastfed infants have a slower weight gain, particularly if fortification is stopped after discharge. But we have learned from large preterm cohorts like the EPIPAGE and LIVE cohort that although they show initial slower weight gain, they have a better long-term growth and also a better neurodevelopmental outcome. So breast milk has not only advantages in the early perinatal periods, but also long-term effects on neurodevelopmental outcome and better growth. Therefore, breastfeeding should be continued post-discharge whenever breastfeeding is possible.
Thank you. Our preterm infants also get older, and so at a certain moment, complementary feeding has to be introduced. So, is there an optimal time to introduce complementary foods to preterm infants, or should this be individualized? Does the timing of complementary feeding impact the growth outcomes?
Yeah, it's a very interesting question, and there is unfortunately not much research available on that. Term infants, it is recommended in term infants to introduce complementary feeding between the 17th and the 26th week of life, which corresponds to the 5th between 7th month. And for preterm infants, such recommendations are not available so far. So we have only data from a few observational studies and from a few randomized controlled trials. And these data show that the timing should be individualized based on corrected age and developmental readiness. So observational and randomized studies, including our own, show that the exact time point of introduction of complementary feeding does not significantly affect growth outcomes. Therefore, the key is neuromotorical readiness, good head and trunk control, disappearance of the extrusion reflex, for example, and also a coordinated hand-to-mouth movements so that complementary food can be ingested.
Okay, and what about the micronutrient supplementation? What are your recommendations for vitamin D and iron supplementation in preterm infants after discharge? And how should clinicians monitor and adjust these supplements?
Yes, we have two critical micronutrients in preterm infants. This is vitamin D and iron, and therefore these two micronutrients should be supplemented during the first year of life. And for vitamin D, we have the recommendation to supplement 400 to 17 units per kilogram per day, not exceeding more than 1,000 units daily, especially in those that are born with a birth weight below 1,500 gram or have other risk factors for growth failure. For example, they have been on long parental nutrition or are suffering from bronchopulmonary dysplasia. So these are the infants that are highest at risk for vitamin D deficiency. The levels should be monitored in these high-risk infants to prevent both deficiency and toxicity, and should be monitored in the outpatient clinic during the first year of life. And for iron, supplementation should be started between 2 to 6 weeks of life, even earlier in infants with a birth weight below 1,000 gram. And the typical dose is 2 to 3 milligram per kilogram per day until complementary feeding is established, depending on the meat intake afterwards, and can be adjusted based on serum ferritin levels, which should be monitored. And it is really important to avoid early iron deficiency, because this can impair growth and neurodevelopment. So proactive monitoring is vital.
So thank you, Professor Haiden, for this very interesting information. I do have a final question for you. Which key message about post-discharge nutrition for preterm infants would you like to give to our listeners?
Yeah, I think there was a change in the post-discharge approach recently. So the new approach is discharge nutrition is not a one-size-fits-all approach, and the success depends more on individualized monitoring, parental support, and timely interventions. And the initial goal should be to achieve proportional catch-up growth, so not just weight gain, but balanced improvements in length and head circumference, while preserving the benefits of human milk feedings.
So thank you, Professor Haiden, for sharing your expertise and practical insights. And thank you to our audience for joining us on NNI Bites Big Learnings. Stay tuned for more conversations where science, nutrition, and innovation come together to build healthier futures, starting from very early life.
And that concludes today's episode. Thank you for joining us for this special episode from NNI and WNSC Workshop 103. We hope you enjoyed and learned from this quick discussion, fellow experts. Till the next episode.